Good evening to everyone and welcome to today's session. Seema, Sandeep, Madhushri, Akash and many more who are all online. Can you be able to punch whether the voice is loud and clear? I hope your NEETPG preparation is running in topmost gear, fifth gear, and hardly another 3 weeks before you go to the fight. That's good. There is a little delay in preparing the PowerPoint slides for today's class. So, before the PPTs arrive, let us start the quiz opposite to what we were doing earlier. So, we will be finishing the quiz, and by the time the regular class PPT in general medicine become ready. Okay, so please start answering the questions. What is the best investigation to confirm the diagnosis of anaphylaxis is a very important question. Yes. You please start shooting your answers, doctor. Yes. I can see Ravi and Komali. Very good. Komali, I'm seeing you first time. Very good. And they're all proposing serum tryptase. Please unfreeze your fingers and start answering the questions. Sandeep also is saying serum tryptase. So, absolutely right. Wonderful. You're all NEETPG ready. What is the most common cause of the aortic aneurysm? A lot of times aortic aneurysm is completely asymptomatic finding, which you should remember. You have done ultrasound for some other purpose and you will discover that there is aortic aneurysm. So what is the most important underlying cause is my question to all of you. Priyanka, Sean Chaco, Santosh Dubey, everyone is saying atherosclerosis. That's right. Elderly people above the age of 65, atherosclerosis weakens the wall and lead to development of aortic aneurysm. Now doctor, these are all the features of hyperparathyroidism, except what? What you don't find in hyperparathyroidism. What is the effect of parathormone on serum calcium versus serum phosphate is an important question. 183, Ravi proposes decrease serum phosphate. Ravi, you should not do this question wrong. I will cry if you do that. And Priyanka also thinks like Ravi. Come on. Sona, everybody, Seema, Pranay, and Pratiti Sharma. Excellent, doctor. Excellent. So, you don't find diarrhea. What is the effect of parathormone, doctor, on the renal calcium excretion? It will make phosphate lost into the urine and calcium retained. So, it leads to hypercalcemia and hypophosphatemia. That is what you have to remember. Now, secretory diarrhea out of all this. Where do you see? Secretory diarrhea. There is an osmotic diarrhea, secretory diarrhea, all of you know very well. So, what is the difference between the two? What are the causes of each of them? Question number 184. Punch your answer, doctor. Very happy to see 113 online students. Santosh thinks glucagonoma. Rocket Raider fires it as medullary thyroid tumor. Sona thinks it is glucagonoma. Good. So, anybody thought it as C? Except as C? Even in glucagonoma, also there is secretory diarrhea, everyone clean bowl. See, you have to, tonight you should decide secretory diarrhea, osmotic diarrhea, what is the difference? Diarrhea is a topic that we discussed in general medicine and gastroenterology. Please go back to the U-Medico app, quickly review, and in pharmacology review, what are the laxatives and laxatives is one topic commonly people do wrong. Yeah. Now, the next question for the today's evening is, yeah, chorionic villus sampling. What are all the conditions for which you will do? That's right. Very tricky question. Rocket Trader is absolutely right. Yes. 185. I can see Ravi proposing phenylketonuria, which is a biochemical defect. And Rocket Trader, are you sure? Saumi, are you sure? Yes. So, absolutely. Trisomic 21, phenylketonuria, Downs, they all can be detected, but not the gastroschis. Sarla Boria is absolutely right. That's right. So, finally, after NEETPG exam is over, these things only will be catching up on your mind. Arre, Hatavidhi, maine kya kar diya? C ko D aaya, D ka C answer kiya maine. So, questions will be simple, especially single liners are like those finest missiles which you should get ready in the tomorrow's exam. 11 beta, 21 beta, 17 alpha, hydroxylase deficiency. You have to be 100% sure of it. Congenital adrenal hyperplasia is a favorite topic of the examiner. Jaswinder Kaur also, Sastrikal, bahut din ho gaya, aap sabko milke. Today our pediatrics teacher has an emergency case. So, I said, Dr. Gopati Srinivas is not available today unexpectedly. So I said that let me take a class. I always enjoy to be with the students. Yeah. So that's right. So you find hypokalemia, hypertension, virilization. These are all the features that you come across in congenital adrenal hyperplasia, but not metabolic acidosis. You have what is called TRALI, transfusion associated acute lung injury. What is the main reason? Why does it happen when you give, Vamshi Raj, I think FMG exam is forthcoming. In fact, all these are FMG questions. Let me be very sure to you. FMG, yes. Right. Papu Singh is asking, add a feature to double speed, triple speed. I'll do that. I will tell. I hope you're all enjoying the notes feature, bookmarking, and creating notifications. This feature of the U-Medico app. Once more tonight, one more version of the U-Medico app is coming up with notifications and portrait view of the slides and everything, right? So, hope you're all enjoying. How do you feel about the U-Medico app's notes feature? There is a video. You click on the video, you will get the relevant video of that particular topic. So, be very sure. Yes, doctor. Thank you, Samsung, for the compliment of awesome. iOS may be not available. iOS may we are coming up with the U-Medico version in another 1 week. That's good. That's good. So, you should remember that it is the HLE mediated reaction which is seen in case of the blood transfusion associated acute lung injury is what you need to remember. Thalassemia. What is the type of inheritance? Is the broadcast okay? In thalassemia, What is the type of inheritance that you see is a very important question. Yes. Indumukhi 180, 188. Yeah. Indumukhi, Sam Singh, Santosh Kumar, Swati Pandey. Everyone is thinking there is a tie-up between dominant and recessive. Always remember, doctor, childhood में आने वाला conditions होता है recessive. Adulthood is dominant. Then complete penetrance and complete expressivity are the features of recessive. Then rate limiting enzyme disorders are all recessive. Structural protein disorders are all autosomal dominant is what you have to remember. Tell me which is that condition which is called X-linked dominant, only one condition. Please type your answer. Who will tell me the correct answer? NEETPG का favorite question है 2019 में. बताओ जल्दी बताओ. Which is the only condition which is X-linked dominant, not recessive. Right? X-linked dominant. Should be your answer, which is that condition which is X-linked dominant. You should punch what is that condition which is X-linked dominant. That's good. Indumukhi, Santosh Kumar, absolutely right. Vitamin D resistant rickets is a X-linked dominant condition is what you have to basically understand. Now doctor, the next question is low serum iron with a low serum ferritin. और एक बार कल FMG एग्जाम में यही क्वेश्चन आएगा, right? Should be your answer. Ravi thinks it is iron deficiency. Absolutely, very easy question. Thrombocythemia, not penia, is a feature characterized by what? Oh, come on. Very easy question. No big deal. Yes. It is classically elevation of the platelets. All of you are right. Cystocytes, where do you see fragmented RBCs? 191. Yes, doctor. Cystocytes, the fragmented RBCs, where do you see? Question number 191. Yes. I can see Akash proposing it as D. Excellent. Any microangiopathic hemolysis lead to development of the cystocytes. What is true about vitamin K deficiency out of all this? What is the correct answer? 191? 192. That's right. Ravi Kumar thinks prolonged bleeding, and will there be any thrombocytopenia? Will there be any thrombocytopenia and vitamin K deficiency? 192. Santosh, Bhuvanesh, everyone is strongly thinking D. Absolutely. Deficiencies rarely seen except in infants. Correct. Vitamin K deficiency is not that common. Warfarin does not cause vitamin K deficiency, but it will antagonize all those vitamin K dependent clotting factors. It is not, but vitamin K is used to treat the warfarin overdose. That is a perfectly correct statement. Then hemolytic anemia is associated with the following gallstones. What type of gallstones? First you should know what is the classification of the various types of the gallstones. Very nice to see 199 wonderful doctors across country who are all online. Right. Question number 199, 193. That's right. It is a pigmented gallstone. 60-year industrial worker, shortness of breath. for the past 1 week. The blood is withdrawn. It is showing thick brownish red color. So what is your diagnosis? 194. So more and more PowerPoints and videos are getting uploaded. The PGI question bank, JIPMER question bank, then AIMS question bank, all these are getting uploaded into the UMedico, where you have the notes and the videos. So nearly about 500,000 slides are there. The PowerPoint slides, 500,000, around 5 lakh slides are there if we include everything, including 150 mock tests and their discussions and the PPTs. So it is up to you. You have the whole world of knowledge review that is available before you. You can be selective and bookmark, set up notification. You can, today night's version of UMedico notes, you can even be able to add a comment. That is one extra feature, so that you can become friends with other people who are commenting on the same slide. That way there is some amount of academic pollination. That is the whole idea, right? Sauni is asking, where is the payment option in the app? Don't worry, you can give a call to our helpline, that is 900-868-356, which they will help you to make the payment in order to access the content, paid content, definitely. So question number 194, you have various, many of you have answered it as C. That's right. It is methemoglobinemia is what you need to remember. Now about cross-matching of the blood, what is accept about it? Cross-matching of the blood. 195. Should you answer, doctor? $195? Yes. I can see Aruna Gangadhar answering it as B. Komali. Komali, you are from which place, doctor? Must be from Andhra Pradesh or Telangana. And I can see Captain Jack. Oh, 2 days I was not there. Other teachers are teaching, and there are a lot of new students. Very good to see all of you. Good. Vizag, right? Very good. So every year, Visakhapatnam students used to be in the top 100 ranks. In those days where Andhra Pradesh PG entrance used to be there. So I'm very happy to see. Please ask all your other classmates, friends also. Please share this channel. It is a free Chai Pe Charcha everyday evening to inspire you. And you also have all this content on the UMedico app. Abundance of content is there on the UMedico app in terms of notes or videos or mock tests. You call anything, you have it. You have a discussion forum on that. Midnight also you wake up, you find another friend who is also working on the app. So, and it is also compatible with the iPad and also the, if you want a bigger screen, right? Now, the answer is, the donor serum is not the one which is tested against recipient's packed cells, but it is mandatory in all cases except in emergency. It is understandable in emergency. You don't have time to do the matching. So universal donors are all O positive, and universal recipients, you know very well. Now, gastric cancer is caused by what is a precursor for the gastric cancer? Yes. Question number 196. Should your answer, doctor? 196. Nischal. Very good. One more new name I am seeing. Nischal is proposing metaplasia type 3. Very good, very good. Excellent. Wonderful answer. Kunal Boyer is clean bowled. What are the most common cancers for the gastrointestinal stromal tumors? GIST is a very, very important question. Very good. Nischal from Nepal, Kathmandu. Very good. So Nischal should invite me for a year-end vacation at Nepal, right? So I can see most of you saying stomach. Absolutely right. A lady presented with iron deficiency, anemia and malabsorption. What is most accurate diagnosis? Very good to see. And shortly, we are starting one more feature in this UMedico broadcast. There are about 40,000 consultants, medical consultants globally. They allow to do the case presentation on this platform. So they pick up one or two very interesting cases. They discuss about everything about that particular case. What were the presenting features, and also a video of they will directly broadcast from their clinics OP room. So you will also have a lot of clinical material happening. One day you have about 4 or 5 cases on gynecology, 4 or 5 cases in dermatology, etc., etc. So we will make it a complete clinical, like a internet TV, YouTube TV. We will try to host a lot more content, which will help not only for PG preparation, for many other things that help you in the clinical practice. Right, doctor? And some of you, when you top the NEETPG exam and join post-graduation, you need to contribute a lot of clinical cases every day. So, doctor, anti-endomysial antibodies. That's right. Our relationship is not going to be tata, goodbye after the NEETPG. When you are postgraduates, please continue this mission of everyday free. Teach the world free, and that's always good. You know, you have seen one case. There is a learning point in that clinical case. First time you have done the hysterectomy or surgery, share that experience. Take a consent of the patient, and you can share the video, and you can be able to present a case. That should be the way, right? That's right. So now comes the question. There is a sensory ataxia, patchy loss of papillae on the tongue. What is the first investigation that you want to do? 199. One confident answer. That's good. Ravi proposes vitamin B12. Vitamin B12. Come on, Ravi. Indumukhi also thinks same as Ravi. Everyone is thinking the same. Nischal also. Nischal thinks it is B12. Okay. Okay. Madhu thinks B12. Absolutely right. A 14-year-old, chronic diarrhea, last 3 months. What is the first investigation that you want to do? 200. So, in the UMedico app, keep posting in the social network some nice questions that are there in your mind, and others will start commenting. And you, nowadays, even notifications are coming. So that will help you to be awake 24/7 on the entrance mood if you want to be. So you can do that. Now, UMedico student community is a big community now, right? All the way from China, Philippines, Nepal, and across India. So that's good. It is an intestinal biopsy, doctor, that is going to be the gold standard. Madhu is absolutely right. That's right. Now, loss of tongue papillae, hemoglobin is 9.5, mean corpuscular volume is 100, that is, it is macrocytic. Then what is the first estimation that you want to perform in this given patient? 201. Shoot your answer. Yes. Ravi thinks A. R. Sharma also. That's good. Vitamin B12. Once it is macrocytic, megaloblastic, it should be the vitamin B12 estimation. Cushing ulcer, not gushing. Cushing ulcer, where do you see? Cushing ulcer. Curling ulcer, where do you see? Easy question. Recent pattern 2016 ka FMG question tha. So 202, everyone is sure it is stomach. Carcinoid tumor ka most common site. Is it appendix or is it ileum? What is Bailey and Lau is nowadays telling? Bailey and Lau. 203. Read Bailey daily. 203. Ravi proposes appendix. Rocket Trader thinks ileum. Good. Monica, come on, don't make me cry. It is not stomach. Maybe, I think Monica's typing mistake. Ileum, doctor, not appendix. 45-year-old, night party, complaints of epigastric pain, penetrating towards back. What is the best investigation that you want to do is a very important question. 204. Ravi and Nagarajan are all thinking A. Only Sujata thinks B. Sujata Chaudhary, you are from Andhra Pradesh or from Kolkata, Chaudhary? From where are you from, Sujata? 204. Very good. It is a serum lipase. Come on, it is pancreatitis is what you need to think, not anything else. Gastroesophageal reflux disease. What is your answer, doctor? 205. Monica thinks it is B. And yeah, Monica thinks B. Most of you are thinking A. Absolutely. 24-hour pH monitoring is the one which is going to help. Very good. Sujata from Bihar. So, very happy to see you. Please join every day evening, Sujata. This session is 365 days. Light or dark, rain or sun, you have the Chai Pe Charcha on at 6 to 8 or 8:30 p.m. every day with Dr. Murli Bharadwaj or any of the other wonderful teachers on this platform, which is absolutely free. Please post it on the Facebook, share it on the Facebook, this link of the channel, and I'm very thankful our subscriber base is very high now, right? Now, a 2-year-old malnourished child, fever, weight loss, tachypnea. Chest X-ray is being shown. What is the best treatment that you want to offer to this patient? 2-year malnourished, fever, weight loss, tachypnea, chest X-ray is shown. Excellent. Rocket Trader, don't only say ATT. Santosh Dubey proposes B. Absolutely. Only ATT. You don't find miliary changes? Miliary TB? ATT, if it is miliary TB, steroids have a role. But anyway, let's recheck that. We'll recheck that answer. Leukostasis syndrome. What is the organ that get affected in leukostasis? Is a very important question. 207. Yes, doctor. Leukostasis. Ravi thinks it is B, spleen. I can see most of you are on spleen. No, it is the lung. Who said D? All of you are thinking leukostasis syndrome affecting spleen. Nobody thought it is lung. Okay. Very good. Shabas is the only one and only Shabas who thinks it is lung. So also Navendu Mohan. Drainage hemothorax is done from which space is the important question. कौन सा space से आप drainage करेगा hemothorax है तो? When do you want to do thoracostomy, surgical thoracotomy, instead of just a intercostal drainage? What are the indications? That is a favorite question of the examiner. So Ravi and everyone thinks it is D. Mohan thinks second intercostal space. Komali thinks fifth midaxillary space. That is called Vishakhapatnam Scud missile, right? Absolutely, Komali Jindabad. So also Pratiti Sharma. Shock lung is synonymous with what? Is an important question. Should not 9. Yes, doctor. 209. Nischal thinks it is ARDS. And I can see most of you saying ARDS. That's good. ARDS. Absolutely. Pneumatocele. Which organism causes pneumatocele is an important question. Right. Pneumatocele. Should your answer, doctor? And even in UMedico app, you can record your own voice for a particular slide that you are bookmarking or setting up a reminder, and that will help you to contribute to the other students. If you have some funny mnemonic, you can't write it actually. You can be able to tell that, and that will help a lot of other students also to go through the media. There's a small button on the top called media about the notes slide. Okay. So all of you download UMedico app and start using it and give me a good feedback. Please write it on the Google Play Store. Our programmers will be very happy that they created world's topmost learning platform, mobile learning platform, right? Now, pneumatocele is caused by Staphylococcus aureus. So that brings us to the end of the questions, doctor. Let us take up the discussion, the regular discussion today. Okay? Can you put up the camera? Now, for the last few days, we were discussing 22 most high-yield topics of neurology in the last 15 years of the All India and NEETPG exam, the top 22 topics. Now, there are few more topics, 8 to 9 topics left. We will complete the neurology today, right? Now, what is the cell that is more sensitive to hypoxia? Cells of the CNS and the neuronal injury is a favorite topic of the examiner. You should remember, it is a neuron which is very sensitive. Hypoxic ischemic encephalopathy. You can see why the brain is so sensitive whenever there is any hypoxia, obviously, right? So, brain is 2% of body weight, 15% of body energy and 15% of the cardiac output. And there are no energy stores in the brain. It purely depends on the aerobic metabolism which is responsible for the hypoxic ischemic encephalopathy is what you need to remember. Damage to the nervous tissue is repaired by which cell of the CNS is a very important question. It is the neuroglia. So those who are all online, please continue to punch answers that helps you to solve some more questions, right? So always we should keep challenging our brain. Whole entrance is what, doctor? After the entrance is over, once you get the seat, you don't need to remember a lot of things. In fact, you need to forget a lot of things and start learning new things in the clinical medicine, right? Once you join PG. Until then, you should fully engage every cell in your brain to start guessing going wrong, guessing going wrong. You should solve questions, be sportive and enjoy the game. So, it is the neuroglia which help to repair. So, there are various functions of neuroglia. They provide the metabolic support, immune protection of the neurons, and they outnumber the neurons by about 10:1, the neuroglia. Unlike the nerve which conducts the nerve impulses, they do not. But unlike the neurons, this neuroglia helps to regenerate and repair whenever there is any neurological injury is what you have to basically remember. Swati is asking, क्या है sir? ये microglia नहीं होते क्या? Difference between microglia and neuroglia. I'm also not sure why microglia should not be an answer. Yeah, we'll come back on that. What are those cells that do not participate in the repair after the damage to the nervous tissue? Yeah, microglia participate, astrocytes help, endothelial cells also help, but not the fibroblasts is what we need to remember. So, what are the functions of astrocytes is the question. They help in uptake and regulation of neurotransmitters. They regulate the glutamate. They promote the neuronal survival. They help in myelination. And they also secrete and modify the extracellular matrix. So, neurogenesis, synaptogenesis, everything they help. They do immunomodulation. They regulate the blood-brain barrier. And also, they help to the brain to have glycogen energy reserves. And they regulate the extracellular ions. These are all the pleiotropic effects of the astrocyte is what we need to remember. So, who carries out the phagocytosis in the brain? Once more, the All India Examiner, NEETPG Examiner is very sure on the nerve cells repeatedly. The reason is, this topic of nerve cells is there in the question bank of the examiner. He has no control on what questions out of that will come, right? So, but if you know what is the topic which is sitting in the examiner's question bank, you are all well prepared. So, out of 30 questions in general medicine, 7 to 8 questions come from neurology. Out of that 7 to 8, now you know that there are 22 topics which are sitting in the examiner's question bank. From there, all the hits will be coming. So, that is how you should be well prepared. So, in the UMedico app, there is one of the courses called 650 high-yield topics. Please go through that. There you have all the 650 high-yield topics, the notes on each topic, the theory notes, review notes of this PowerPoint slides and the video. So, every time you are falling short that this topic I am not good, immediately review in the high-yield topic notes and video, go and play the quizzes. It is all auto preparation. You yourself should know that I am doing good or bad. The knowledge is all there. But where is the motivation to read? Chai pe charcha every day evening. The purpose is to add that motivation to you. Okay. Now, it is the microglia which carries out the phagocytosis. So, if you look at neuroglia, there are two types. Microglia and oligodendrocytes. Oligodendrocytes, they form the myelin for the CNS, central nervous system neurons. Who is the counterpart of that in the peripheral nervous system? It is called the Schwann cells. Whereas microglia, they provide all that immunodefense, and it is very important in Alzheimer's and multiple sclerosis, AIDS, and other neurodegenerative diseases may. It is the microglia associated immune defense which is very important. If you look at the blood-brain barrier, this is the most capillaries, how they look like and how brain capillaries look like. Most capillaries there are pores through which passage occurs, and in case of the brain capillary, these astrocytes processes are there, no doctor? These processes of the astrocytes, they help in forming this blood-brain barrier is what you have to basically remember. Now, if you look at the glial cells, 90% of the CNS cells are all the neuroglia, and they support both physically and metabolically, and 4 major types of neuroglia include astrocytes, oligodendrocytes, microglia, and ependymal cells. So, if you look at the various glial cells, you have a ependymal cells which are like this, which are the one which are lining the CSF. Then you have the astrocytes which are contributing to the blood-brain barrier by sleeving around the capillaries. Then you have the oligodendrocytes which are producing the myelin around the nerves. That's how your white matter is being created. And you have various microglial cells which are doing the policing job is what you have to ultimately remember. So, main function of astrocytes kya hota hai? It is the main connective tissue in the brain, and it will take up the neurotransmitters. It removes all that excessive potassium. This is the main function of astrocytes, and it is activated by various neurotransmitters. Ependymal cells, they line the cavity where the CSF is flowing, and it is a common source of a brain tumor is what we need to appreciate. Now, what are those modified macrophages in the brain basically called as? They are called as microglia. Now, which is not a part of reticuloendothelial system, which is not having the, which is the one which is having the origin, not the knot, but having the origin of reticuloendothelial system. Microglia are more or less like the peripheral phagocytic system, so it has got a role. So, in the CNS, you have ependymal cells, oligodendrocytes, astrocytes, microglia, whereas in the peripheral nervous system, you have satellite cells and Schwann cells is what you have to appreciate. Now, microglia are implicated in certain disorders, especially leading to tissue injury. In Alzheimer's, multiple sclerosis, it is a microglia which plays the dirty job is what you need to remember. Negri bodies, they are those intracytoplasmic eosinophilic inclusions that you see in the case of the rabies. Where do you find? Which type of cells do you find? Is a very, very important question. So, Negri bodies are eosinophilic, they are sharply outlined, pathognomonic inclusion bodies, they are found in the cytoplasm of certain nerve cells, which are containing the virus of the rabies, especially pyramidal cells, which are the source of origin for corticospinal tract. In the hippocampus, there is a Ammon's horn of the hippocampus. Pyramidal cells in them are the ones where you find the Negri bodies is what you have to basically appreciate. So, this is how a Negri body look like. Once more, doctor, Cowdery type A, Cowdery type B, what are intracytoplasmic, what are intranuclear, what are basophilic, what are acidophilic. Oh my God, life is miserable, right? But only another 2 to 3 weeks you have to bear that, right? So, we discuss all these things in the pathology. DNB is a folder in the UMedico app. You go to the DNB. In that, in pathology, you have inclusion bodies, one of the topic. Tonight only you have to review that video, play a quiz. It is one of the high-yield topic also. Play the quiz on that after listening to video, bookmarking the notes. That is what you need to basically do. Now, this is a micrograph where you can see numerous rabies virions and negri bodies which are considered to be pathognomonic cellular inclusions of the rabies is what you need to appreciate. Rosenthal fibers, where do you see? Then also intracytoplasmic inclusions. So these are called the Rosenthal fibers. What is so characteristic? How do you describe them? They're worm-like, corkscrew, eosinophilic bundles on H&E staining in the brain whenever there is any long-standing gliosis. Some of the tumors have a nature to create a lot of gliosis, and also in some metabolic disorders. So they are pink, eosinophilic bundles, and two conditions you should remember: Rosenthal fibers. Pilocytic astrocytomas, Alexander's disease. There was also one question asked in the past about this Alexander disease, if you remember, while we were discussing the Ames question bank, right? So Rosenthal fibers, once more a favorite question. Where do you see? It is a pilocytic astrocytoma where we find the Rosenthal fibers. This is a squash preparation which is showing Rosenthal fibers where bipolar astrocytes are showing thin cytoplasmic fibrillary process on H&E staining, which is staining pink, is a classical feature. Once more, NEETPG 2015, 2012, 2013 का repeated question है. Rosenthal fibers are composed of what? You should remember, it is the heat shock proteins they are composed of. They are the intracellular inclusions. They represent the fragments of the GFAP and the protein building block of the glial intermediary filaments and other proteins like heat shock proteins. So, heat shock proteins and Rosenthal fibers, GFAP. Like this only. Few words here and there, you remember, sneeze it in the exam, you are done. Right off. That is the story of the various neurons, etc., etc. Just like JIPMER, PGI and DNB question bank में, FMG में, Alzheimer's is such a favorite topic. Ames also. All India may be, NEETPG may be, Alzheimer's is a favorite topic of the high-yield topic. What is except about Alzheimer's in this? Neurofibrillary tangles are intracellular inclusions. Fact. Amyloid plaques are extracellular deposits. Fact. Destruction of the cholinergic neurons in the nucleus basalis of minute. Fact. But what is wrong is, it is not the short-term memory loss. It is a long-term memory loss is what you need to remember about Alzheimer's. Alzheimer's कैसे evolve होता है? Very good to see 200 online students enjoying across the country, all the way Bihar ke Sujata Chaudhary to Komali in Vizag and Nischal in Nepal. I am so happy, Khush Hua Mogambo. So please call your other friends also to join this. And please subscribe, share, and there is a bell sign in this YouTube channel. Please click on the bell so that the notification keeps coming to you. Right though. Now, when the Alzheimer's is very early, my patient will have memory loss, language problems, mood changes, personality changes, diminished judgment. People think, oh, this elderly man, age related, they think. Then he will be unable to learn or recall new information. Long-term memory is the one which gets affected. He starts wandering, agitated, and he requires assistance for the activities of the daily living. Ravi Kumar is asking, what is the short-term memory loss? Good one. Huh? Short-term memory loss means you moved from first year MBBS into second year MBBS. All your class girls said, "Chi, get out." But suddenly, the new admissions happened and your junior girls came. Still you have courage to go and propose with a rose because you had a short-term memory about all your classmates who rejected you. That is short-term memory. Long-term memory loss means 6th class mein when you have proposed love, that time that first girl whom you proposed love slapped you. That was a long-term memory loss that you forgot it. Right? Now, unstable gait, incontinence, bedridden, dysphagia. That is a typical severe type of a Alzheimer's is what you need to remember. Neurofibrillary tangles, where do you see classically in Alzheimer's. So tomorrow's examiner, अगर ये histological slide दिया है आपको, will you recognize? You should, because you know Alzheimer's is something examiner want to try creatively to give you a question. So pyramidal cells of the hippocampus and the cerebral cortex may you find the neurofibrillary tangles is what you need to remember. Alzheimer's type 2 astrocytes, Alzheimer's में नहीं दिखता, कहाँ दिखेगा? Alzheimer's type 2 astrocytes are not seen in Alzheimer's. They are seen in chronic liver disease, hyperammonemia, Wilson. पहला Alzheimer's type 2 astrocyte क्या होता है? There is an enlarged nucleus inside the astrocytes that you are seeing here. That is the Alzheimer's type 2 type of a astrocyte is what you need to remember. It is basically a pathological cell in the brain, and whenever an astrocyte is swollen, it will show a large nucleus and a significant nucleolus, which is called Alzheimer's type of astrocyte, type 2. And normally they may be found in brainstem, cerebellum, cerebral cortex and thalamus. And hepatic encephalopathy, Wilson's disease like conditions also, Alzheimer's type 2 type of a astrocyte is a feature. Rapidly progressive dementia, where do you see? HIV dementia, doctor. One case if you see, no, you will never forget. Patient will completely forget. He is almost like an Alzheimer's, emaciated with the HIV, right? HIV dementia is very rapidly progressive. So, if you look at HIV dementia's spectrum, you have cognitive problems, motor problems and behavioral problems. A poor concentration, forgetfulness, slowness of thought and cognitive dysfunction. They are all the problems that are cognitive. Gait instability, urinary urgency, saccadic ocular pursuit movements, slowing of the repetitive movements, they are all the motor features. Apathy, loss of interest in friends and hobbies are the behavioral changes. So cognitive, motor, behavioral, that is how HIV typically, dementia typically presents. Abhi aa gaya numerical wala question. Right, doctor? If you know, you know, otherwise you have to put a revolver in your mouth and shoot it. That's the only option here. So chromosome 1, chromosome 21, chromosome 19, अगर एग्जाम के टाइम पे आपके दिमाग के अंदर याद नहीं आए तो इट इज लाइक वैरियर करना, राइट टाइम पे वो मंत्र की याद भूल जाते, राइट? So that should not happen in NEETPG. You should be fighting like Partha, Arjuna, not like a Karna, right? So 21 में APP होता है, and onset is very early and increased production of AB42. Chromosome 19 के ऊपर ApoE is a gene defect, and onset is late. And it is a tau protein hyperphosphorylation and impaired production and polymerization and clearance of the amyloid beta protein is the one which is responsible. Ravi says Karna is stronger than Arjuna. Stronger weak no one counts. Jo jeeta wahi Sikandar. So chromosome number 14, chromosome number 1. 1, 14, 19, 22, you should remember about Alzheimer's, dementia. At least you should not suffer dementia in exam. Now, these are all the inclusions in Alzheimer's disease. Except what? Already we discussed examiner's favorite question. Lafora disease. I don't know whether we discussed it in our Sunday mock test discussion or NEETPG neurology. Somewhere we discussed, right? Lafora disease. All that glycogen deposition, etc. etc. So, senile plaques, neurofibrillary tangles, cerebral amyloid angiopathy are the classical features in Alzheimer's is what need to be remembered. So, this is a very high magnification of a cerebral vessel where amyloid deposition is there, which is stained positive with the Congo red stain, and there's the MRI which is showing those low signal foci in a patient who has a cerebral amyloid angiopathy. Whenever patient is having dementia, doctor, what are the 3-4 things that come to your mind? Is it a regular senile dementia? Is it Alzheimer's type of dementia? Is it vascular dementia? Whenever you have cerebrovascular accident and your brain is burnt due to ischemic injury, you get dementia, which is called vascular dementia. Then you have amyloid angiopathy associated dementia. So these are all the things that you need to remember as a broad classification. After finishing MD Pediatrics, MD General Medicine, some of you are going to be top neurologists, right, doctor? So, and some of you are going to come on this floor and inspire many more students preparing for entrance. And some of you, when you join PG, be ready to present some interesting clinical cases. One case, one student every day. Wow, what a great contribution you will be doing to the entire medical education across the country, across the world, right? So, that should be the spirit. Alzheimer's may, what is except out of this? Temporal lobes, medial temporal lobes, classically involved in Alzheimer's. You find neurofibrillary tangles, amyloid deposits, but not, sometimes family history is not always negative, it is positive. So in Alzheimer's, if you look at the imaging findings, CT और MRI में देख के बोल सकते हैं आप कि Alzheimer's है बोल के. If you want to quantify, you have to do structural MRI. Then how is the distribution of atrophy that you see in the case of the Alzheimer's? Hippocampus, entorhinal cortex is first to get affected. Then posterior cingulum, then medial temporal lobe, insular cortex, prefrontal cortex, orbitofrontal cortex, and in late stage may diffuse bilateral symmetrical shrinkage of the brain is what you are going to ultimately see. Yes. So these are the normal medial temporal lobe doctor. यहाँ देखना है आप जब भी Alzheimer's है. In case of Alzheimer's, you get the shrinkage of the medial part of the temporal lobe. This is very, very important to be remembered in case of the Alzheimer's. Sam Singh says, sir, one story of Alzheimer's bolo. Yeah. I can never forget my own teacher, and she is also the medical superintendent of the hospital where I got trained. Her husband was a top radiologist from All India Institute. They had a wonderful love marriage in medical college, then post-graduation also they married, and they both did it in All India Institute, and he had Alzheimer's. Such a wonderful radiologist, forgot everything, and there was, she being a medical superintendent, there was one special room created for the gold medalist radiologist with Alzheimer's. He used to keep shouting the entire night. The ward used to have a high resounding sound. He used to continuously yell at the people. So that is the first case of Alzheimer's that I have seen. Even attended the autopsy after he passed away, that I can never forget. Right? So now, what is not seen in Alzheimer's is a very important question. So you should remember sundowning, apraxia, and cerebral atrophy. When cerebral atrophy is there, the ventricles in fact will expand, they don't shrink. That's called Hydrocephalus Ex Vacuo is what you need to basically remember. But what is meant by sundowning phenomena is a very important question. So whenever the symptoms like restlessness, irritability, disorientation, mood swings, they all happen towards the end of the day. That pattern is called the Sundowning syndrome. So as NEETPG aspirants, why 6 p.m. to 8:30 p.m. or 8 p.m. we have this chai pe charcha? You should not get that sundowning syndrome while preparing for a battle on January 6, 2019. In Alzheimer's, what is deficient in the cerebral cortex, which is that neurotransmitter, is a very important question. So, it is acetylcholine, tacrine, all these drugs, how do they act? They increase, they are the acetylcholine esterase inhibitors, tacrine. So, they increase the acetylcholine is what you should remember. Now, progressive loss of the neurons at the Maynard's nerve locus, cholinergic neurons, is responsible. That is few things on Alzheimer's in the last 3-4 years of NEETPG. Let's talk about myopathies, one of the favorite topic of the examiner. Already I told you, doctor, there are two types of muscle weakness. Proximal muscle weakness like your shoulders and your hips, distal muscle weakness like your fingers and the toes. Neuropathies lead to distal muscle weakness. Myopathies lead to proximal muscle weakness. General rule. There are exceptions, but general rule. So now the examiner says, where you don't find proximal myopathy. Neuropathies may generally it is distal. Whereas Duchenne's, thyroid myopathy, they're all the examples of the proximal myopathy. So you ask the patient to get up from sitting position. What are you testing? Proximal myopathy. You ask the patient to button unbutton. What are you testing? distal myopathy. That's what you need to appreciate. So, what are the causes of the proximal myopathy? You can easily remember myopathy itself. Metabolic, iatrogenic, osteomalacia, paraneoplastic, alcohol, thyroid dysfunction, hyperparathyroidism and immune or idiopathic. They're all proximal myopathies is what you have to basically remember. Yes, a very good question asked by Ravi is, how about myasthenia gravis? Ocular myopathies are more than the proximal myopathies, but proximal myopathy is found, right? Now, this is one slide, doctor, I'm trying to tell you. It's one favoritely asked question. So, in the UMedico app, under this topic of myopathy, this PPT get uploaded and there you can bookmark it if you feel that you will forget it. And another thing, there is a feature called sort. When you go to a particular topic, no, you have all the slides available. There is a feature called sort. Sort according to most viewed slides I want first, or most bookmarked things I want first, or those slides which most people have set up a reminder I want to see first. You can be able to sort it and then review it. If you don't have time for reading all in the original order. Suppose you want the original order to be restored, you can say, get back to the original default order. Then the slides get arranged in the default order. So that is the main advantage. So please keep using the discussion forum, and we want you to be alive like a WhatsApp. We're always on WhatsApp, like that on the UMedico until NEETPG exam is over. So doc, if you look at the nerve associated weakness, it is often distal weakness. So if it is involving lower extremities, neuropathies associated muscle weakness involving lower extremities, then the patient will give a history, tripping attacks, dragging the feet while walking, and you ask him to wear the slippers, he will have a difficulty. And suppose if he has a neuropathy involving upper extremities, then he will have the problem with the grip, or he will be dropping down the objects. If it is asymmetric only on one side, think that neuropathy is because of some nerve compression. If it is symmetrical weakness, then the possibilities are metabolic neuropathies like renal or diabetes is what you need to remember. Now doctor, unilateral ptosis is a feature of the myasthenia gravis, Hanco's, squamous cell carcinoma, apical part of the lung when it is involving, it leads to the compression of the sympathetic chain leading to Horner's, as all of you know very well. It is also unilateral ptosis. Then Marfan. But thyroid ophthalmopathy, if you take, it is a bilateral ptosis is what you typically come across. Parking lot inclusions. Honestly बताऊं, मैं भी पहली बार सुन रहा हूं आज. To teach you, I keep learning every day. A parking lot, I thought, maybe is it any wrong typing, I thought. Definitely there will be no barking lot, right? Or a barking pot. So, parking lot only. So, ये क्या है बोल के research करे तो mitochondrial myopathies में अगर आप electron microscopy से देख रहे तो it looks like you are standing on the top floor and looking at the parking lot on the ground. They are called parking lot inclusions. So on the electron microscope, mitochondrial paracrystalline inclusions looks like a parking lot is what you need to remember. So if you look at the parking lot from distance, from the top floor, they also look similar to that. Mitochondrial inclusions in mitochondrial myopathies is what you have to basically remember. This is a beautiful question. I am waiting for this specific question. Difference between dermatomyositis, polymyositis. इन दोनों के बीच में क्या फर्क होता है histologically? Doctor, there will be some questions you should always have in pocket. Reading room जाते ना, take मिसाइल के जैसे दोस्तों के ऊपर खुश करना. अगर वो शांति से पढ़ रहे तो क्या मजा है, उसके दिल में अशांति की जागृति होना है. So you have to keep pushing some missile like question. ये भी मालूम नहीं है क्या तुझे इंट्राफैसिकुलर है या एंडोमाइसियल है, और बॉब नीट पीजी में फूड प्रोग्नोसिस बोल देगा. तो दैट इज कॉल्ड कॉन्फिडेंस assassination program. You should be, we used to be experts in that all the time while preparing for entrance, right? So be very sure. Perifascicular atrophy is seen in the case of the dermatomyositis is what you have to basically remember. So you have atrophic muscle fibers at the periphery of you can see the fascicle. That's called perifascicular atrophy. That is what is classical of dermatomyositis, is what I want to underscore to all of you. So you can see in the perifascicular region there are necrotic and regenerating muscle fibers in the perifascicular area, classically seen in the case of the dermatomyositis. So if you take poly versus dermato, you should be very sure. Somesh is asking what are the other signs, sir? You have to go back to U Medico, DNB question bank में, AIMS question bank में, PGI question bank में, high-yield topics में, हर जगह dermatomyositis, polymyositis is one of the top 20 topics in neurology that we discussed, debated, delivered. So you need to review over there, but I want to tell you, polymyositis, dermatomyositis is a high-yield topic of any examiner you should be very sure about. So polymyositis में symmetrical proximal muscle weakness involving the striated muscle, voluntary muscle. CPK levels are highly elevated in polymyositis. And if you do muscle biopsy, characteristic features, EMG में characteristic features. And polymyositis is the one, Ravi is asking a question, malignancy किस में होता है? Polymyositis में होता है malignancy. It can be paraneoplastic polymyositis. Polymyositis is more commonly seen in the case of the females, 2:1. And 45 to 60 years is the age of polymyositis. Rare in pediatrics. Blacks more often affected. And that is the story. Whereas dermatomyositis, there are specific dermatological manifestations like Gottron's papules, Scholl sign, V sign, heliotrope rash. They're all dermatomyositis. And muscle biopsy, there are differences between dermato and poly. But dermato is more a pediatric problem, is what you need to remember. Poly is P, but it is not pediatric, right? And dermato is basically pediatric, is what you have to remember. So there are three common differential diagnoses always in the neurology. Dermato, polymyositis and inclusion body myositis. Slowly progressive weakness is the feature of slowly progressive inclusion body myositis. But poly and dermato, it is a subacute progression. Patient will tell, 3 हफ्ते के बाद बहुत अच्छा हूँ डॉक्टर साहब, देखो मेरे हाथों को there is I attended a marriage also and still they have applied mehendi to me also. A 45-year-old female is telling you. 3 हफ्ते के बाद मैं ठीक हूं डॉक्टर साहब, तब acute progression, classical feature. Then it is the adult women polymyositis, whereas children is dermatomyositis, and adult men is inclusion body myositis. Periorbital heliotrope rash in dermatomyositis, and you find myopathic potentials which are spontaneous activity is a feature in all the 3. Elevated serum creatinine is a feature of dermato and poly but not inclusion, and in case of dermato, it mainly affects the perimysium with perifascicular atrophy, whereas endomysial involvement is a feature of polymyositis, and inclusion body myositis also, it mainly affects the endomysium, but there will be chronic nature. It is not subacute. That is a classical feature. So doctor, but before that, what is fascicle? What is endomysium? What is perimysium? ये तो जरा knowledge रहना है हमको. You have a border of the muscle bundle which is called fascicle. You have normal muscle fibers. इनके बीच में एक blood vessel है. So when normal muscle fibers, if you happen to see, you can classically appreciate fibers, blood vessel and the fascicle. Polymyositis में क्या हो जाता? There are inflammatory cells which are invading the muscle fibers, and the muscle fibers, because of that invasion, will become rounded, and ये बहुत बड़ा है, ये छोटा है, और ये moderate size में है. Different shapes of the muscle fibers typically are seen. Inclusion body myositis में क्या होता है? You have inclusion bodies, and within the muscle you find vacuoles, which is the classical feature of inclusion body myositis. But dermatomyositis may classically, there is a shrinkage and atrophy of those fibers which are nearer to the fascicle, and the inflammatory cells are found around the fascicle, and between the fibers is the classical, between the fibers. एक fiber दूसरे fiber के बीच में you will find, and even around the vessel, which is the classical thing of dermatomyositis is what you need to remember. So, in the UMedico app, go to the notes, go to the NEETPG bullet points. In that medicine के अंदर ये topic load हो जाता है. उसका notes में that particular slide, if you feel last moment you need a revision, you can always be able to bookmark it. So, I want to see every time you are viewing a particular topic, I will see this many number of people viewed this. I will be very happy. Then every time you are entering into a particular slide, I will see this many number of people viewed this slide. Very happy. You are bookmarking, I will get the statistics. If you are keeping it as a reminder, I will get the statistics. And that is going to help a lot, because majority of you are setting up reminder to a particular point means that gives opportunity for teacher to do analysis as to how to make it memorable for you guys, because you're all marking it as a reminder. So we do run a lot of analytics on your behavior on the UMedico app notes and the videos, and accordingly that insights will help us to personalize the learning for each of you. In the form of notifications, they will tell you that hey man, you have not checked that particular point that you have set up a reminder. So that's how we will help you, right doctor? So ragged red fibers is applied for which condition? So you should remember mitochondrial myopathies अगर आप लिए तो there are ragged red fiber disorders and non-ragged red fiber disorders. That's how mitochondrial myopathies, mitochondrial disorders have been classified. Very good to see 210 online students. How many of you are first timers? Today or yesterday first time yahan aaye hain? Please give a mention that who are the first timers and from which place are you from in India. So please type. Ragged red is Guillain-Barre syndrome, MELAS. What is MELAS? Mitochondrial encephalopathy with lactic acidosis and stroke-like episodes is called as MELAS. Then MERF, which is myoclonic epilepsy with the ragged red fibers. Very good. Anup Chandran from Kerala. Bhavya Sri Sai Vejandla from Andhra Pradesh. So please come every day. Post it. Tell all your friends that there is a free class. 6 to 8:30. This Dr. Murli Bharadwaj fellow is a very crazy guy. Free class every day. There is nothing free, doctor. Ultimately, we will give free here and try to collect the fee from the U-Medico subscription. Nobody is noble in this world always. Yeah, but we need to pay for the server, technologies, everything. So, if you subscribe to our video library, it will be a great help for us to support this mission, right? So, please give a call to our helpline 9000868356. They will help you to get the subscription and activate your account. So, progressive axonal ophthalmoplegia, Pearson syndrome. This was also a favorite question, the JIPMER question bank. Very good. Amir from Coimbatore, definitely. And Captain Jack from Mumbai. Please come every day. All is perseverance. Every day to be in the game. That is the only way that you will be able to win this game called NEETPG, and my job is every day to inspire you. Leaks encephalopathy, NARP syndrome. NARP में क्या होता है? Neuropathy, ataxia, retinitis pigmentosa is called NARP syndrome. They are called non-ragged red fiber disorders which come under mitochondrial myopathies is what need to be remembered. Very good. Papu Singh and Brahmanaidu from Guntur, excellent. So, every time I go to the Guntur Medical College and deliver a class, at least 200 students used to come in Vijayawada, Guntur, Visakhapatnam and everywhere, right? So, nowadays, every day I am able to meet around 200 to 300. So, this is how a patient of the ragged red fiber syndrome, if you have done muscle biopsy, looks like. And there will be periodic lateralized epileptic waves which are classically seen, and basal ganglia calcification is another important feature which you need to remember. Very good. Dhana Disha is from Ranchi, excellent doctor. So muscle tone, whenever it increases, tone is different from strength. A muscle weakness जो होता है ना, +1, +2, +3, वो सब weakness की बात है. Tone क्या होता? Whenever you have cerebellar dysfunction, you get hypotonia, pendular knee jerks. Whenever you are having a stroke, a cerebrovascular accident, you get spasticity. If you have an extrapyramidal lesion like Wilson or Parkinsonism, then you get rigidity, which is high tone state, is what you need to remember. So, paratonia, where muscle tone increasing on patient relaxing, is typically called paratonia, is what you need to ultimately remember. That's good. Ravi is saying, I'm a big fan of you, sir. Oh, I am a very big fan of Ravi also. Ravi likes many students. Yes. Spastic rigidity is a feature of basal ganglia, extrapyramidal lesion like Parkinsonism. Whereas What is meant by paratonic rigidity? How is it different from spasticity or rigidity? What is the difference? Whenever the intensity of a passive movement is increasing, then the paratonic rigidity also increases, which is the classical feature of paratonic rigidity. And you will get a feeling that, hey, is this fellow is trying to resist, but actually he is not resisting. The more and more you are increasing the intensity of passive movement, the more and more will be the resistance. That is called paratonia, is what need to be remembered. Arsenic poisoning. Classically, where do you see? Is an important question. Arsenic poisoning causes polyneuritis, is what you have to remember. So, there will be a peripheral neuritis, encephalopathy. They are all the features in case of the arsenic poisoning. Patient is having acute onset, acute, very important, eryplexia, quadriparesis, blurred vision, no pupillary reflexes, 20-year young male. On telephone, you should give the differential diagnosis for this given clinical condition. It is botulism, classically. So, descending symmetric motor paralysis. And what is the triad of clinical features in botulism, which you should not forget? Bulbar palsy, a clear lucid sensorium, and no fever, no fever. That characterizes the botulism. आई में क्या क्या चेंजेस होता है botulism में? Blurred vision, diplopia, ptosis, sluggish pupil response, etc., etc. Then dysarthria, dysphagia, all because of the bulbar nuclei affected, and abdominal pain, cramps, diarrhea, etc. will happen, and respiratory impairment. They are all the features of botulism. Now, a 60-year-old female has got a proximal muscle weakness, increasing serum creatinine kinase. What is the most likely diagnosis? Already CPK level high means polymyositis, doctor. If the patient tells you, डॉक्टर साहब मैं स्क्वाटिंग पोजीशन से उठने में बहुत दिक्कत हो रहा है, आंध्रा में पेरेंटम बोलते, पेरेंटम बोले तो एक फंक्शन को जाना, इसको पेरेंटम बोलते. आई स्टिल रिमेंबर वन ऑफ माय पेशेंट्स, धनलक्ष्मी, शी सेज अगर पेरेंटम गए तो आई एम अनेबल टू गेट अप फ्रॉम द स्क्वाटिंग पोजीशन डॉक्टर when I sit on the floor. Proximal muscle weakness. You send the blood sample, CPK level will be very high. That is the place where you will discover the first case of the polymyositis that you have seen. So that is very important. High levels of the CPK. The next topic is intracranial pressure. So increased ICT में क्या होता है? ब्रैडीकार्डिया होता है, midriasis हो सकता, systemic hypertension, and there is a reduction of the Glasgow Coma scale. They are all the true statements. Benign intracranial hypertension, otherwise called idiopathic intracranial hypertension. What are the features that you see? Ventricles classically will be normal. Lateral rectus palsy because of the abducens involvement, papilledema. They are all the features, not proptosis. So, Dandy's criteria, they are called as. In 1937, of course, I was born in 1973. Dandy was proposed in 1937. So, what are the Dandy's criteria? There are signs and symptoms of increased intracranial pressure. No localizing signs. Only abducens neuropalsy will be found. Normal composition of the CSF is very, very important. And ventricles will be either normal sized or slit sized in imaging, and no intracranial mass was the original Dandy's classification. So बाद में Neuro-Ophthalmological Society proposed modified Dandy. What are the modified Dandy? To diagnose idiopathic intracranial hypertension, signs and symptoms of raised ICT, no localizing neurological signs except bilateral sixth nerve palsy, no evidence of intracranial mass lesion if you do CT, normal CSF composition. That is a modified Dandy after taking a brandy. So this is benign intracranial hypertension, and it can lead to irreversible visual loss. It is a normal optic disc, is optic atrophy, is what you have to appreciate. Now, whenever head injury is there, a child is brought to you, how much you should maintain the intracranial pressure is the examiner's favorite question. 5 millimeters of mercury is what you should remember. A simple numerical. If you remember, good. Idiopathic intracranial hypertension का treatment कैसे देते आप? That is the favorite question of the examiner. So, whenever you are treating idiopathic intracranial hypertension, no visual loss, mild visual loss, severe visual loss. That is how you divide the people into. Idiopathic intracranial hypertension according to the Dandy's criteria is achieved. No visual loss. Then you give low sodium dye, 10% weight loss. Generally obesity and idiopathic intracranial hypertension are closely associated. Give esazolpide. If it is mild visual loss, then you need to do optic nerve sheath fenestration or CSF shunt. And you have to do 24-hour blood pressure monitoring and sleep study to look for sleep apnea. With a severe visual loss, then low sodium dye, 10% weight loss, eskezolamide, and optic nerve sheath fenestration, and you have to do a shunt. They are all the important part of the management. Increased intracranial hypertension. Kahan dikhta hai? What do you see in that? That is called Cushing reflex. Hypertension and bradycardia is what you come across. Normal CSF pressure hai, but ventricles are dilated. What is that condition called as? It's called Hydrocephalus Ex Vacuo. So, if you look at the brain which has undergone atrophy, the cortical atrophy leads to a compensatory dilatation of the cerebral ventricles, which is called as Hydrocephalus Ex Vacuo. There is a shrinkage of the brain substance, damage to the brain. Generally, it is a stroke or vascular dementias, chronic neurodegenerative illnesses. You get the Hydrocephalus Ex Vacuo, which is a hydrocephalus consequent to the brain atrophy, is what you need to remember. False neurological sign क्या होता है? False neurological sign is mock test में poor performance दिखा के main NEETPG actual exam में अच्छा rank आ गए तो that is false neurological sign. So also neurological signs are called false localizing if there is no correlation between the anatomical abnormality and the clinical sign. And cranial nerve palsy, especially sixth cranial nerve palsy, is the most common false neurological sign. Glasgow scale, without that there is no question paper. Recently also Ames questions we have discussed, no doctor. There also you can see, we said GCS is going to come, it has come. So, motor 4 क्या होता है? Motor में 5 localizes pain, 4 withdraws from pain, 3 flexion, 2 extension to pain, and 1 is none, is what you have to remember. Yes. We have some more slides. Yes. So there are 2-3 more topics. We will finish the discussion. Let him load the new quiz, new PPT. So our guys also like a garam masala. Railway station में निकलने के बाद वो बनते रहते ना, before the train starts you have to pick up, like that. Somewhere traveling in the car or in some meeting, I'll prepare the PPT, and our guys prepare the final PPT. Sometimes it get delayed like this. Right, doctor? Sweetie, already quiz was over. We started with the quiz. First half an hour time pass quiz se kiya. So, I think first quiz and then lecture is better, or first review and then lastly quiz is better. Please give your feedback. Based on that we will decide. Yes. True about Guillain-Barre Syndrome. What is except about it? Right. So, it is not descending paralysis. It is ascending paralysis is what we need to remember. Very good. Shabaz, Vandan, everyone is saying first quiz. Good, good. This kind of things help. I am thinking last quiz is better, but some more of you vote for the first quiz. Then from tomorrow we will only start with the quiz. Okay. So, how do you describe acute post-infectious demyelinating polyneuritis, which is called as the Guillain-Barre syndrome, is my question. Typically, onset is gradual. Lower extremities are first affected. The guy has a difficulty to walk. Then trunk, then upper limbs, then bulbar muscles, then flaccid tetraplegia. That is what will happen. So it's called Landry's ascending paralysis is what you need to remember. Proximal and distal are involved relatively symmetrically. At the onset there will be severe muscle tenderness. A lot of times people think it is dengue fever or chikungunya, but suddenly patient has a difficulty to walk. Then they do a CSF, discover albuminocytologic dissociation, and then declare it as Guillain-Barre. That's what commonly happens. Some cases may paresthesias, but it is a post-infectious demyelinating polyneuritis. Neurons are what? Androhonsens and neurons are called LMN. LMN में क्या होता है? Reflexia होता है. इसलिए reflexia is a classical feature, is what you have to remember. So, that's good. Khanna Jaideep always gives a very good, liberal, balanced answer. Either way, it is okay. Anything in life is boring, doctor, when we do it repeatedly. So, one day I saw, one day quiz first, one day theory first. We'll do a case control trial to keep ourselves sailing the ship forever, right? So, rapid, progressive, ascending paralysis, acute onset, intact sensory, please remember, and generally no bladder involvement. So, commonly, what is the differential diagnosis of acute flaccid paralysis, doctor? Poliomyelitis, Guillain-Barre, transverse myelitis, and traumatic neuritis. Any of them can present with acute flaccid paralysis. First, poliomyelitis may, there is a bulbar polio. So, the lower cranial nerves can become involved. Possibility is there in polio. Guillain-Barre may 7th, 9th, 10th, 11th, 12th, often they get affected. Whereas transverse myelitis खाली spinal cord में होता है. Myelitis बोले तो spinal cord का inflammation है. So no cranial involvement, so also traumatic myelitis. Respiratory insufficiency. Yes, it can happen with Guillain-Barre and poliomyelitis. Sometimes transverse myelitis में हो सकता है. So that's the reason Guillain-Barre अगर है तो ventilator ready करके रखना. Any moment he may end up in respiratory embarrassment and you need to get him on ventilator के ऊपर चढ़ाना पड़ेगा. Bladder dysfunction. Polio में it is a pure motor anteroconsal involvement, nothing to do with any of the parasympathetic or sympathetic plexuses. So bladder involvement is never a feature of polio. अगर है तो it is not polio. Whereas transverse myelitis में parasympathetic plexus, thoracolumbar, craniosacral, any of them can get affected depending upon which part of the spinal cord myelitis is seen, and it is often seen. Whereas Guillain-Barre में sphincters are not involved, but still they will have retention of urine. Why? Because if you have to pass urine, micturate, you need to generate an intra-abdominal pressure by contracting your abdominal muscles. What happens in Guillain-Barre is, there will be weakness of the abdominal muscles so that you don't get sufficient pressure to pump out the urine. That is responsible. Not because of sphincteric involvement. But transverse myelitis में bladder involvement, bladder dysfunction, urinary retention is all because of sphincters become affected. That's what is the main difference. So, per se sphincteric involvement is not seen. Then at 3 weeks if you do EMG, Guillain-Barre will be normal, transverse myelitis is normal. They both are luckily transient phenomena, but poliomyelitis continue to be abnormal. Then if you do nerve conduction studies, typically demyelinating or axonal damage associated nerve conduction velocities, typically pattern is shown in Guillain-Barre at 3 weeks. If you look at the sequelae, what is the outcome? Polio, all of you know, there is asymmetrical atrophy, later skeletal deformity in case of the polio, whereas Guillain-Barre may, since it's a neuropathy, acute post-infectious polyneuritis, neuropathy hai. So neuropathy involves distal muscles. Most of the times Guillain-Barre, milder cases may, if you quickly initiate IV immunoglobulin, then there is a good recovery, nothing happens. But if you ignore it, then symmetrical atrophy of the distal muscles is a feature of Guillain-Barre, is what you need to remember. Whereas transverse myelitis may, there is a diplegia and atrophy after a few years. That is a important differences. Guillain-Barre may, what is here, sir? Albuminocytologic dissociation, normal cells with a increased protein. Shabazz is saying, sir, जरा EMG और nerve conduction velocities के ऊपर भी खत्म करो ना. It is already there, doctor. It is there in the DNB question bank, video library, and our theory video library. Many occasions we discussed. So just take an opportunity to review those videos in the UMedico app. Now, doc, Guillain-Barre may, what is except? IV immunoglobulins we give, plasmapheresis we do, but steroids have no role. That is important point to remember. There is a strong evidence that plasma exchange helps, IV immunoglobulins help, combination help, but steroid usage is not going to help. So when they are in early stage in acute disease, then you should admit them immediately into hospital because any moment they may need a ventilator help. Then you need to do IV immunoglobulin, and earlier days when IV immunoglobulin is not that commonly available, plasmapheresis used to be the major part of the treatment. But plasmapheresis in Guillain-Barre, it's a nightmare. Why? Guillain-Barre में there is an autonomic instability. Plasmapheresis से क्या कर रहे हैं आप? पूरा प्लाज्मा निकाल के मशीन में भिजा के फिर बॉडी के अंदर चढ़ा रहे हैं. Can you do that in a person who has autonomic instability? Suddenly BP will fall down to 60, 50. Suddenly it will rise to 200, 210. So it becomes a challenge to do plasmapheresis with someone with autonomic instability like a Guillain-Barre patient is what you have to basically remember. A man has acute onset of paraplegia, symmetrical, bilateral, areflexia. He will jump on the examiner, hold his neck and strangulate it and say, I know it is a Guillain-Barre you are going to ask. उतना कॉन्फिडेंस के साथ अटैक करना डॉक्टर, एग्जाम हॉल में बैठ के आसमान में देखते हुए गेसिंग करना वो नहीं होता. यू शुड 625 टॉपिक्स में बराबर कितने टॉपिक्स आए तो इसमें क्रिटिकल पॉइंट के ऊपर पूछा या नहीं. दैट इज हाउ यू शुड बिफोर गोइंग टू एग्जाम यू शुड नो 2 to 3 critical points, classical points in all 650 topics. Be ready, exam become a game. मिलर-फिशर सिंड्रोम क्या होता है, इसमें क्या दिखता है? एंटी GQ1 एंटीबॉडी. अगर गुलेन-बारे पेशेंट को क्रेनियल नर्व पैल्सी हो गया, वो होता है मिलर-फिशर. एटैक्सिया भी होता है मिलर-फिशर. एटैक्सिया, एरिफ्लेक्सिया, ऑफ्थेल्मोप्लेजिया is Miller-Fisher, and 1/4 of them also have the acute flaccid paralysis. Electrophysiological studies में there is sensory conduction failure. It is the anti-ganglioside antibodies which are typically abnormal is what you need to remember. Once more, the Guillain-Barre में you have Aman, Amsan and Miller-Fisher, 3 varieties. So areflexia, ataxia, ophthalmoplegia, anti-GQ1 antibodies, Miller-Fisher, that's all. For the exam, that much is enough. Palpable nerve kahan dikhta hai? Where do you see? It is the Charcot-Marie-Tooth syndrome where you find a palpable nerve. So what is Charcot-Marie-Tooth? There are a group of disorders which are called hereditary, motor and sensory neuropathy. उसमें motor neuropathy होता है, sensory neuropathy होता है और वो hereditary होता है, HMSN. So what are the different types of the HMSN? Charcot-Marie-Tooth type 1 which is called hypertrophic demyelinating neuropathy. मतलब नर्व को पकड़े तो मोटा मोटा बन जाता है, thickness of nerve will increase. Type 2 is axonal type. Type 3 HMSN is Dejerine-Sottas disease, which is autosomal recessive. And Refsum's disease is type 4. And optic atrophy is seen in type 6. Retinitis pigmentosa के साथ HMSN हुए तो type 7. That is how you broadly classify. So, HMSNs and Charcot-Marie-Tooth is one of the common inherited neurological disease which progresses gradually, occurring in early childhood. What is common underlying problem in Charcot-Marie-Tooth? There are certain genes that produce the proteins which will help in the myelination of the peripheral nerves. If there is any genetic defect there, then myelination of peripheral nerves is affected. So any neuropathy happens to the distal muscles. So feet, lower leg muscles are affected. It leads to deformities, tripping and falling episodes, and lower leg bulk of the muscle is typically decreased, and that leads to a typical appearance called reversed champagne bottle appearance. मतलब lower part of the leg में it is thinned out, upper part of the leg में it is still bulk is there. That's called reversed champagne bottle appearance is what you see in Charcot-Marie-Tooth. And long-standing cases में pes cavus abnormality is what you classically see. So patients will develop hammer toes, claw toes, etc. in this. Then thoracic scoliosis. And what is it? Problem in hereditary sensorimotor neuropathy is a problem of demyelination. So that is the reason. Absent deep tendon reflexes, diminished vibration sensation, sensory ataxia, essential tremors, sensory neural hearing loss, they are all the other important problems. Isaacs disease. What are the classical features? Too much neurology, doctor. अंडरग्रेजुएशन में मेडिकल कॉलेज में कोई भी पढ़ाता नहीं, कोई सिखाता नहीं. एग्जाम में तो एंट्रेंस में डीएम न्यूरोलॉजी का उसके ऊपर के बाप का क्वेश्चंस पूछते हैं. तो रिमेंबर, नीट पीजी इज नॉट ए टेस्ट ऑफ इंटेलिजेंस, एटीट्यूड, एप्टीट्यूड, किसी का टेस्ट नहीं है. ये क्या है? फिल्टर है. फिल्टर मार रहे हैं एग्जामिनर. 10 लोगों को एक ही सीट चाहिए. So there should be, do you have a longer nose, taller height, fairer complexion, lot of money. Before you marry my daughter, because 10 boys are ready to marry. So that is how entrance is all about. So don't worry at all that if your performance is little weak or slow. 4 महीने बैठो मुरली भारद्वाज के साथ. यू मेडिको में पूरा वीडियो लाइब्रेरी अवेलेबल है. सीट नहीं मार आए तो Dr. Murli Bharadwaj, soul will be heaving in graveyard. So be very sure, doctor, not a test of your intelligence, it is a smartness. Did I finish that 650 topics? That is what you have to strongly think. Now, Isaac disease में peripheral nerves बहुत excitable हो जाता है. होने की वजह से क्या होता है? Because of the excitability, continuously nerve will be firing. That lead to muscle stiffness, stiff man syndrome, and continuously contracting, twitching, cramping, lot of sweating, and delayed muscle relaxation. That is called Isaac syndrome. Called continuous muscle fiber activity syndrome is a simpler name, is what need to be remembered. A patient after having an alcoholic drink falls asleep in the chair overnight, hanging his arm. Saturday night palsy. What type of injury it is? One of the last 20 साल से यही क्वेश्चन पूछता है एग्जामिनर, right? So doctor, you should remember different types, Sudden's classification. Neuropraxia कहाँ दिखता है? Demyelination. Any minor contusion or compression. There is a preservation of the axis, and impulse transmission is only physiologically interrupted. So radial nerve compression, like in the Saturday night palsy is an example. Complete recovery मिल जाता. So neuropraxias में endonurium is intact, axon is intact, only pressure बाहर से थोड़ा press कर रहे हैं. Then axonotmesis, there is a demyelination plus axon loss. It is a more significant injury. This leads to distal Wallerian degeneration, and there is a preservation of Schwann cells and endoneurial tubes, and crash injuries, displaced bones में आपको axonotmesis दिखता है. यहाँ भी spontaneous regeneration and functional recovery होता है. So endoneurium is intact, axon is damaged, distal end will show Wallerian degeneration, and there is a combination of demyelination and axon loss in case of the axonotmesis is what need to be remembered. Then neurotmesis में क्या होता? Endoneurium भी मर गया, उसको बोलते हैं neurotmesis. Unless you surgically do something, the patient don't improve. So distal end will have Wallerian degeneration, endoneurium is damaged, axon is also damaged. That is called as neurotmesis is what you need to remember. So neuropraxia में myelin damage, physiological conduction block होता है. Axonotmesis में axon damage होता है. और neurotmesis में you have axon plus endoneurium plus perineurium plus epineurium, सब कुछ damage होता है. That's what you need to remember. Next comes the EG. Rademacher complex in EEG. पहली बार मैं भी पढ़ के समझ के आपको सिखा रहा हूँ EEG में, right? So I'm also part of the अमिताभ बच्चन का कौन बनेगा करोड़पति में अमिताभ बच्चन will not know actually the answers of all the questions. At least he will not know even 1% of them. A teacher is not about knowledge. Teacher is all about drama. I am very good at drama. So that is the reason I could become a good teacher for you. So don't worry. Entrance is like that. If you are going to become a dermatologist or a forensic medicine guy, why do you need Rademacher complexes but for passing the entrance exam, doctor? Chalo. It is seen in subacute sclerosing panencephalitis के EEG अगर करे तो आपको दिखाएगा SSPE में. So the EEG is showing these Rademacher complexes which are polyphasic high voltage periodic discharges with a slowly underlying background is what you need to understand. Thank you, Abhishek. Thank you very much. I was a worst student. Oh my God. You are 100 times better than me. फिर भी I became a state topper and got in MD General Medicine during my time. But always my students used to be 1,000 times better than me. Right? So, it's a question of attention deficit disorder जिसको नहीं रहता है उसको जल्दी आ जाता entrances में top ranks. But life is more beautiful. You have this boy or this girl with whom you need to hang out, and you have that postponement syndrome in the brain. All these dysfunctions will, you yourself will put up speed brakes for yourself. That is the whole problem of entrance preparation. So these are called those R complexes. A patient of subacute sclerosing panencephalitis has got myoclonus in the muscle. So he is showing the presence of the R complexes and myoclonic jerks. That is a typical feature which you need to remember. So yes, EEG में metabolic encephalopathy में कौन सा waves दिखाएगा is a very, very important question. So you should remember it is the delta waves that you need to remember. So whenever metabolic encephalopathy is there, you find triphasic waves, diffuse slow activity is what you see in metabolic encephalopathy on EEG. And how will EEG help? Severity of encephalopathy can be judged by the appearance of triphasic waves. Prognosis के लिए it will help. And to know how effective your therapy after you have given sufficient therapy and metabolic encephalopathy resolves, triphasic waves also resolve. That is what you classically need to remember. So doctor, the different important EEG waves and their significance. Please go back to the UMedico. By tomorrow, this PPT and this video become uploaded into your UMedico app in the notes and video. So this is one question definitely entrance में ये table से निकल के आएगा. Intermittent rhythmic delta activity. Where do you find? In structural brain disease and metabolic encephalopathy. Triphasic waves, you see it in encephalopathy. Then periodic lateralized epileptiform discharges called PLEDs. Where do you find? Whenever you have any structural or a focal lesion like ischemic stroke, abscess, brain tumor, etc. Bilateral independent periodic lateralized epileptiform discharges called biplets. Where do you find? anoxic encephalopathy. Then burst suppression pattern in EEG. Where do you see? Anoxic encephalopathy. Then in the EEG comas, you should remember, electrocerebral inactive pattern, ECI pattern it is called as, when there is no EEG activity which is exceeding 2 millivolts, then you call electrocerebrally inactive pattern carries poor prognosis, especially when patient is in a coma stage. You don't know whether shall I remove ventilator or not, shall I remove life support or not, you are not very sure. So you need to do an EEG to discover. Alpha coma. Whenever there is anoxia after a cardiac arrest and a poor prognosis, if there is alpha coma. Spindle coma. Classically seen in the case of the, case spindles are there, no? So that is seen in head injury. But spindle appearance of a lot of case spindles is a good prognosis in head injury is what you need to ultimately remember. And beta coma, where do you see? Beta waves. Benzodiazepine barbiturate overdosage agar koi liye to lot of beta waves in a coma patient, and that carries a good prognosis is what you need to remember. Hips arrhythmic pattern on the EEG kahan dikhta hai? Infantile spasms classically shows a hips arrhythmic pattern. So this is a classical ECG where you have a lot of hips arrhythmias where the background is chaotic with bursts of bilateral asynchronous high frequency waves is what you need to remember. So this chaotic high to extremely high voltage polymorphic delta and theta rhythms are the classical feature of the hips arrhythmia is what I want to underscore to all of you. Now a mother noticed her 6-year-old child having abnormal twitching in the face during the sleep. Very important clue. Centrotemporal waves are found on EEG. What is your diagnosis is the examiner's favorite question. It is called Rolandic epilepsy. Centrotemporal epilepsy is the name which is being given. 2 to 12 years is the common age group. Peak is in 5 to 10 years. And there will be simple partial seizures which are seen infrequently. Tingling of the mouth, on the face, speech arrest, etc. Rarely people develop during the sleep GTCS. That is another thing of Rolandic epilepsy. Generally by puberty, good news that you can tell to the mom is the Rolandic epilepsy resolves by puberty. And high voltage centrotemporal spikes bilaterally, classical of Rolandic. But if you do the neuroimaging, it will be normal. It will be normal. Now, one of the question is asking by Neta Mahesh is, why not it be myoclonic epilepsy? No, myoclonic epilepsy में सलाम spells होता है, suddenly गिर जाते, टेबल के सामने बैठता लड़का myoclonic epilepsy में, thak, he will have a myotonic spike, then he loses the tone and falls forward. That's called salam spell. Then generally treatment is not needed for the Rolandic epilepsy, and it is considered to be a idiopathic focal epilepsy. Is what you need to remember. Now, EEG may less than 3 Hz polyspike activity is seen. Abhi Chandran is asking a beautiful question. Abhi Chandran is asking a beautiful question. Room number 19 is asking, sir, please keep this video on the YouTube tomorrow. I will be very happy if room number 19 joins, takes a subscription. Please give a call to 9008683566, our helpline number below. For a throwaway price, they will give you a subscription of the entire video library mock test for 1 year. And this video and these notes, everything will be available on the UMedico app, no worries. Less than 3 Hz polyspike activity, where do you see? Lennox-Gastaut syndrome is what you need to remember. So 4-5 points about Lennox-Gastaut, you should all remember. Peak period is between 3 to 5 years. More common in boys. It is a childhood onset epilepsy. But sad news is, Lennox-Gastaut kills the child, unfortunately. High mortality. And sudden unexpected death in epilepsy called SUDEP is common in Lennox-Gastaut, and the child ends up unfortunately in status epilepticus. So what is the classical triad of the Lennox-Gastaut syndrome is my question to all of you. Multiple seizure types, cognitive impairment, and a EEG pattern which is showing the slow spike and wave pattern is characteristic of Lennox-Gastaut is what you need to remember. So in the Lennox-Gastaut, you have several seizure types: tonic, atonic, atypical absence, myoclonic, partial, generalized tonic, etc. Then there is something called non-convulsive status epilepticus. Very important. Status epilepticus may you expect a lot of muscle activity, no? In some people, EEG करे तो आपको epileptic waves दिखता, मगर patient is not showing any kind of a muscle activity. I can never forget, the patient was also a doctor, and his wife was our forensic professor. And that man used to have, drinking alcohol used to be his regular habit, like breakfast, lunch, dinner, all the time. So he was sitting and just standing, looking stably towards the TV, not moving at all. She checked the BP, normal. She checked the pulse, there. He is breathing, but he is only remaining like a statue. Then she gave a call, and I was a resident that time, went running. First case of non-epileptic, non-convulsive status epilepticus that I can never forget. Okay, so that can happen. And characteristic EEG abnormality, interictally slow spike waves which are less than 3 Hz, 2 to 2.5 Hz are the characteristic features of the Lennox-Gastaut syndrome is what you have to basically remember. So this is another slow spike and wave activity EEG. Sometimes paroxysmal fast activity will be found, and that is the story. Now, generalized periodic epileptiform discharges in EEG, kahan dikhta hai? Whenever there is herpes simplex encephalitis, you can see the temporal lobes involved classically. You find PLEDs, which are periodic epileptiform discharges, is what you come across in herpes encephalitis. Once more, favorite question of the examiner. मैं बोला ना, UMedico के notes में, the earlier slide I have shown, no, alpha coma, beta coma, and all that. Bookmark it and set up a reminder, right? PLEDs slowing on the EEG. Where do you find? In herpes simplex encephalitis, the EEG with PLEDs, 65-year-old man who has herpes simplex encephalitis, is having periodic epileptiform discharges is what you classically are seeing. So doctor, with this we will call it a day, and thank you all. Please don't forget to subscribe to this YouTube channel. Make your friends also tonight to subscribe, another 100. If 200 of you can bring another 100 of your batchmates, We will have 20,000 students every day enjoying a free session. That is my dream. And you are the ones who are going to help me to get more subscribers, popularizing this. And all 365 days, I promise to be on the side of you, whether rain or light. So just wake up with full courage. Don't let any negative thoughts come to you that सीट आए तो क्या होता, नहीं आए तो क्या होता, मुझे रैंक कैसा आएगा, किस मेडिकल कॉलेज में ज्वाइन होता, वो सब भूल जाओ. Right? So what did Lord Krishna said in Gita? Without expecting the phalitam of karma, without expecting the outcome, keep battling and emerge as a victorious warrior. That is what you need to apply in your real life. Thank you very much and good night.